Okay, at this time I would like to introduce Crystal Amore. She's Fulton Montgomery's MISA Senior Class President to introduce our second speaker.
Our second speaker this morning is Ms. Paulette Peterson. Ms. Peterson is a professor and clinical coordinator for the Monroe County Community College School of Radiologic Technology. She teaches courses in the radiologic sciences, including radiographic positioning, radiographic exposure, advanced imaging, quality assurance, radiographic processing, professional ethics, mammography, and clinical experience. Ms. Peterson has an extensive background in radiologic management and quality assurance and holds her registry in radiography, mammography, and quality management. She is a member of numerous different professional committees and organizations, including but not limited to the Association of Educators in Radiologic Technology of the State of New York, Association of Educators in the Radiologic Sciences, New York State Society of Radiologic Sciences, Rochester Society of Radiologic Technologists, and has served in many leadership and chairperson roles. She was the recipient of the Association of Educators in Radiologic Technology of the State of New York Dedicated Service Award in 1999 and was awarded an Excellence in Leadership Award in 2002 by the New York State Society of Radiologic Technologists or Radiologic Sciences Education Committee. She has also recently been awarded the Meritorious Service by NYSSRS. Please join us in welcoming Ms. Paulette Peterson as our next guest.
Thank you. Thank you very much. It's very, very nice to be here. Happy to be here and see some people I know and meet new people. Isn't it funny how long all our titles are, all our associations? It's really a mouthful. When you try to call a hotel and say, well, I would like to book rooms for the New York State Society of Radiologic Sciences, they get like bleary-eyed. And all of our organizations are kind of like that because radiologic technology is long in and of itself. And when you do all that stuff that she was talking about, it means that you've been around a long time. So let me tell you right up front, talking about the olden days is okay as long as it's instructional. So when I talk about the olden days today, in some cases I'm going to be talking about 3 or 4 years ago, before most places had all electronic imaging. Those of you who know me or have ever heard me talk or have ever had me as a teacher know that one of the things I do is tell a story for everything. And my life is one big story. And this project, doing this white paper, is really no different than anything else that's ever happened to me in my life. So today we're going to talk about the findings of a task force that I was appointed to that came up with this white paper, and to let the practitioners in the field of radiologic sciences become more aware of some of the best practices. And this came about because it came to the attention of our professional association, another long one, the American Society of Radiologic Technologists, that we were being given direction by groups that were not technologists. For example, if physicists were writing papers about the use of digital technology, and the ACR, the radiologists, were writing papers about the use of digital technology, and here we, the users of it, were not doing anything about it. So ASRT took the initiative to bring this group of people together to create this paper. So because I have a story for everything, I just wanted to tell you that well, I'll tell you the story in a minute. Let me just show you one thing first, because I want to close this out. I'm not illiterate with technology, but I am not the greatest with it. The white paper that was created can be found, I wanted to show you this, at the ASRT website, which is www.asrt.org. And if you go over here to News and Research, you'll see there's all these things, and here's white papers. And the full paper that I'll be talking about today is right there, and it's called Best Practices in Digital Radiography. And this is the full paper. Now, if you get the journal from the ASRT, there was an executive report in, I think it was the fall, like September, October issue, that had sort of a summary of this whole article. If you read the whole thing, it's really kind of long, and it's 38 pages or something like that, but it's worth every bit of reading. So please take the time to go and take a look at the entire article. What I'm going to be giving you today is sort of the executive summary of the findings, but this talks a lot about the background of the paper and why we did it and who we got the information from. So, Gesundheit. That's just the cover of what I just showed you. So this is the working group that created this white paper. And most of these people are educators. Tracy Herman is from the University of Cincinnati. She was just elected president-elect of the National Educators Group. Terry Fauber is a professor in Virginia. Julie Gill is from the University of Cincinnati. Denise Orth is another author. There's myself. Randy Prouty is a program director in Nebraska. Andrew Woodward is the physics and exposures type professor at University of North Carolina, I think Chapel Hill. And then Teresa Odell and Colleen Hoffman were practicing RTs. What's interesting about my getting into this group is I don't know why I was there. I didn't know exactly what a white paper was. We hear the term a lot, and there used to be a show years and years ago when I was a young girl called CBS White Paper Report or something like that, where they always did these specials. I remember my parents used to watch them. So I did some research to find out exactly what a white paper is. And it turns out it's an authoritative, well-researched statement of principles and practices by authoritative types of people. So I said, well, okay, all those people are pretty authoritative, but I'm not. I didn't, I'm like many of you, started working with this with very little, if any, training, and have figured it out over the years as I've been going along. Well, it turns out one of our friends, Ann's and my friend, we serve on the board with him, of the New York State Society of Radiologic Sciences. Bill Brennan is on the board of the American Society of Radiologic Technologists. In fact, he was just elected president-elect for that organization. And the board selects the people who are going to do these kinds of things. And we all fill out volunteer forms to get on these various commissions and committees and that. You may get picked and you may not. So Bill, they bring in this stack of people who volunteered looking for people for this task force, and Bill said, oh, you should pick Paulette because I remember her doing lectures on this at the New York State Society meeting. Well, that wasn't true. It was the woman I work with, Eileen Doyle, my program director, and one of my co-faculty at the time, Dominic DeMichael, who had done the presentation. And I don't know, Bill just thought it was me. So I get selected, and I said, I don't think I should be on this board. I told Eileen, I said, I think it should be you. She goes, no, I don't want to do it. At any rate, once it's done, it's done. So I ended up being in this group. So authoritatively or not, I will do my best to give you the results of our findings and talk a little bit about the process. Of that group, I think I mentioned 2 of them are authors. So imagine me sitting there with these authors talking about information that I was somewhat shaky on. Denise had just written this book, and these 2 had just been published within a few months of us being on this task force. So I was pretty intimidated. And then the ASRT staff members, when you do these projects, ASRT always assigns somebody to work with you. One is a board member, and one is from their office staff. So these ASRT, as wonderful as they are, have many, many vice presidents. And these are 2 of them. Greg Morrison is vice president of everything. He's like the keeper of all knowledge there. And Leanna Watson is the director for practice standards and professional practice issue type things. And we'll talk about some of that a little bit later. Sylvia Wiley was our transcriptionist, secretary, administrative assistant type. And then, this was pretty interesting, they hire people to do the actual writing of the paper. And so that's what makes a white paper different from a research paper, just in case anybody's ever wondered. A white paper, being an authoritative type of statement from a group of authoritative people, we don't necessarily do the writing of the paper. The research we did was from existing material, where research papers, in their purest form, is research initiated and conducted by the author or authors of a study, and then they publish their reports, and they do all the writing. So in this case, they hired this writer, which I thought was a pretty interesting gig for, like, retirement or something. But she sat there, and we just told her what to say, and she would be doing all the typing kind of things. And she kept coming up with the various versions of the paper, and we got a chance to correct it and modify it and that kind of thing. So just to go back to this little group for just a second, and then I'll go to the full slides. as I said, Tracy's from Cincinnati, and Terry's from Virginia, and Julie's from Cincinnati, and we're from all over the place. I actually live in Buffalo, and Randy's from Nebraska, and Andrew from North Carolina, someplace like that. And because I have a story for everything, we always hear about the weather in the Northeast and the snow up in the north and all that kind of thing. Well, when you're on this kind of a task force and ASRT has appointed you to be part of it, they don't expect you to put any of your own money into it. So they do the travel accommodations, and they set up your overnight accommodations. So we all met in Albuquerque just about a little more than a year ago in March, and you get together around this big conference table, and we all brought all of our research sort of to the table to give to the contract writer. So we all had to fly in. So my flight was coming in to Albuquerque, which is 2 hours behind us, at about 12:30 in the afternoon. So it's a full-size plane, one of those big planes, and it's flying in, and they make one of those announcements. We're going to discontinue service because we're going to be facing turbulence. If you've ever flown, you know that feeling like, oh my God. And flying into Albuquerque, I've never flown into Albuquerque in all the times I've gone there where it's been a nice, gentle landing. It's always very bumpy because there's big mountains around there, and it's sort of like in a valley, I guess. So when they're saying that, when we already know it's going to be bumpy, and then they're saying it's going to be worse, I don't like that. So we're going in for our little landing, and all of a sudden, you know how you're going in, and the whole plane goes meow and turns in the other direction, and the pilot comes on and says, we've been rerouted to Santa Fe. They just closed the Albuquerque airport because of a dust storm. I said, dust storm? Wow, that's new for me. But you hear things about dust storms and plane engines. You've heard those stories. Well, anyway, they take us to Santa Fe, and turns out Santa Fe has a teeny little itty-bitty airport that doesn't accommodate big planes. It only accommodates those little jets and small private-type planes. So we land, and the whole plane, it was so windy, the whole plane is like doing this kind of thing. It's a big, huge plane. And so, they have the whole big discussion. Are they going to get us off there? What are they going to do with us? We can't go back to Albuquerque. That airport's closed because of the dust storm and high winds. Like the sustained winds were 78 miles an hour. So finally, to their credit, they got us off the plane there, and they put us in these little itty-bitty shuttle buses that they take you like from the terminal to the parking lots in, those little buses. They brought in about 8 of them, and people were just like all crammed in. It was like that scene in Home Alone where they're trying to get back home. And we get to Albuquerque. So I get there at a reasonable time. And I was the only one who made it because my plane had come in early enough, and they took us to Santa Fe. The rest of that group, most of them ended up in Denver. One ended up in Dallas. One ended up in Salt Lake City. Actually, the chair, Tracy, ended up in Salt Lake City. She ended up going back to Cincinnati and never made the meeting. She was on the conference call for like 12 hours the next day. About 5 of them met up in Denver, rented a van, and drove into Albuquerque for about 8 hours in that wind through the Rocky Mountains. I mean, you learn your geography when you do this kind of stuff. Like, who knew that's what the Rocky Mountains were? But they drove through in that terrible, terrible wind, and they never got in until like 4 in the morning. So the bottom line is this paper was the work of very exhausted people. But I think it came out okay, and I think that's mainly because of the contract writer. But in case if you ever wonder, this is not that dust storm, but that's sort of like what it looked like. When you're in Albuquerque, there's a big mountain there called Sandia Mountain. And this is just all interesting, I think. Sandia Mountain is, when you're at the top, you're at 10,000 feet above sea level. Albuquerque is actually higher in altitude than Denver. They just call Denver the Mile High City because it's like officially 1 mile high. But Albuquerque has a higher altitude, and those of us who go out there a lot, you feel the effects a lot. When you go up to the top of that mountain, which I've done once or twice, you really feel that effect. Well, that mountain is huge, and it looms over the city of Albuquerque. You couldn't see it for the dust. That dust was just as thick as a blizzard is here. So we all have something, and that's what I started to say. Everybody has some kind of weather that becomes an issue at some point. Bad thing about this is it was blowing in your eyes, and there was just stuff all over. I mean, it made the news. It was unusual even for them, and everything was dirty and dusty the next day. I mean, it was just interesting, and I'm glad I never have to do that one again, hopefully. Interestingly enough, the president of the ASRT flew home that night. Apparently, they reopened the airport, and he said when he was landing, his plane's one wing hit the runway. It went like this. His name is Sal Martino. He told us the story the next day. So it was interesting to get there, but we did it. So why we did it, as I said a little earlier, and just to reiterate, is because the ASRT felt that as a profession, we should be the ones dictating how the electronic imaging should be being used. And there's an extra word, research, there that shouldn't be there. But for those of you who are students, this probably just makes no sense to you, but for those of you who have been techs, especially techs for a long time, this technology for us was so new and different from what we were used to that it was excessively overwhelming. And from a teacher's point of view, it was frightening and embarrassing because, you know, there was those months where I couldn't answer questions, I couldn't explain why things were happening the way they were. We had many conferences like this where people would come in and tell us things, and one speaker would say one thing, the next speaker would say another thing, and everybody was confused. And the problem with it was, we weren't really trained in it. When they first installed a lot of this electronic imaging, whether it was the imaging plates, computed radiography, or the direct capture type, what did they say? Anybody? Don't change anything. You don't have to change anything. Just use what you always use. Well, that really isn't the case. And, but people were clearly misled on that, and it's because, as wonderful as this electronic imaging technology is, it wasn't developed by rad techs. These people who developed it had no technical knowledge in the same way that we, as rad techs, have it. So students, bear with us, and you're learning. See, this will never be an issue for you because this is all you're learning right up front. For us, you know, we had to relearn and redo our thinking, and so a lot of this is addressing that. And this article is really geared towards a lot of us who are out there working without any real proper training. So hopefully it will help reiterate some of the things that Ann was talking about this morning. I hope we don't contradict each other on things, because there's nothing worse than that. But I don't think we will, because I know she used this paper to kind of back up some of her research. So here we go. Where did we do our research? Well, we looked at all kinds of different sources. We were each assigned, each member of the task force was assigned something to do, and we were given, it was kind of interesting, they gave us access to what they call the extranet, and that's where we were able to put all of our research as we were gathering it up prior to our meeting as a task force. So our research was done through general research that had been published from various sources, and what was kind of embarrassing is, from a technologist point of view, there was no research at all that had been done in the United States. Every bit of research that we got on it was done in England and Thailand. I mean, just crazy places where you honestly don't even think they have technology like that, but that's just me. Professional associations like the physicists and electronic engineering kinds of people and the software developers. And we went to the ACR to look at the radiologist recommendations, because up until that point, they were the ones telling us what we were supposed to be doing. They were the ones concerned about things like dose. And then the vendors such as Carestream. I will talk about Carestream a lot because I'm from Rochester. I work in Rochester, and that's where Carestream was Kodak, and so you know how that all goes. It's all that. So we had decided early on that these were going to be the elements of the paper. Radiation safety, of course, is in the news, and it's the big focus and big push within our field. It's amazing that it has to be a big push and a big focus in our field. One would think that it would automatically be part of what we do. And yet so many people, in a large part because of the way the electronic imaging was introduced to us, a lot of people are misapplying and misusing technique. And therefore we're ending up with what we call dose creep and overexposure and poor collimation, things I'm going to talk about in there. So we wanted to make radiation safety the #1 focus of the paper, and the radiation dose. And patient safety, and not just in dose, but in the way patients are being entered into systems with risk systems and all the different variations of the risk systems and the way work lists are developed. And I will ask for show of hands in here periodically just because I'm curious. Exposure technique, coming up with the right technique, and I'll go over with you some of the correct applications of technique. Making sure our positioning, which we should always be worried about, but making sure it's correct because it's more important than ever with electronic imaging. The way quality assurance is done, and the amount of collaboration that has gone by the wayside because of electronic imaging. So those are some of the areas that we'll talk about. I just wanted to say that in terms of patient dose, that everything I'm going to talk about here and everything that's in the best practices paper, and I know that's a busy slide and a lot of them are, but this is exactly out of the executive summary. There is absolutely nothing new as far as concepts and theories. It's exactly what you are either being taught as a student, what you were taught as a student. Nothing has changed. It's almost like a reminder to do things the right way. And if you do things the right way, you can rest assured that your images are going to come out in pretty good shape. I just wanted to ask here, is everybody using electronic imaging? Is anybody using film screen in here? It's interesting because, okay, there are a couple. Believe it or not, it's like 60-40 still in the country. Studies have shown that about 40% of facilities are still using film screen. So don't be misled into thinking that you never have to know about film screen stuff. The good news is, as I just said, if you have an understanding of the basic concepts of what you're taught in school, it will apply to both your film screen and your computer CR type imaging and the DR direct capture imaging. And it's interesting, we went over, how many of you have strictly CR, the imaging plates? So few of you. How many? And it's interesting because one of the guys on this committee, his wife's facility was just switching to CR that week. I mean, you think everybody's got the DR and CR, but they were just switching over that week just to the CR. They hadn't brought in any kind of DR yet. Most of you probably have some mix of the two. There's a little bit of DR and a little bit of CR that you use. You know, maybe CRs for portables or something like that. So we went over and over about what to call this in the first place. And we decided to call it digital imaging just as a general term because it is all digitized at some point. But we do want you to understand that there is a distinction between CR, computed radiography with the imaging plates, and the direct capture, which is when, you know, it just goes right onto the detector. But the concepts and principles still are the same. So this is number one, and it seems so sensible that it seems odd that it would make it into a white paper such as this. Carefully review the exam ordered, prevent duplication, and assure appropriateness. This is nothing new. This is something we should all be doing all the time anyway. What the problem is with some of these work lists and in the RIS, and I can't tell you how many different ones there are. Every department has its own little way of doing those orders. How many of you in here are completely paperless? Yeah, that is very, very nerve-wracking because you don't have anything in your hand to go and help you confirm things. How many of you are totally electronic with your charts? Yeah, where I work, and when I say we and me, I'm talking about my clinic site, which is Rochester General Hospital. They've been kind of ahead of the game on all of this. They went completely paperless with charts and with radiology orders a while back. Even big places in Rochester, like Strong Hospital, are still using paper charts as backup. I don't know exactly how it works because I don't go there, but our clinical faculty are telling us that the students, the patient's chart is coming with the patients when they're inpatients. At Rochester General, it isn't. So this is problem number one. Everything is in that computer. If you make even the slightest little mistake, you can pull up the wrong information. And maybe that's not a problem for the technologists, but it is for the technologists who are full-time. But if you're, say, a per diem, and you come in and you're only there once every few weeks or something like that, you can see the mistakes that can be made. And I'll tell you this, at Rochester General, just because of where it is located in the city of Rochester, you'll get many, many patients who have similar names. And I have a slide that I show my students every year. One day, a couple summers ago, the work list went Vasquez, 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 Velasquez, Velasquez, and it was Rosado, Rosario, and none of them were together. It wasn't a family, it wasn't an accident, they were all different. I don't know if there was a clinic or what. So on that work list, they don't come out alphabetically. The only thing you have is sort of your time when they're entered, and it's real small print, and it's very, very easy to do the wrong patient. And to tell you the truth, it's been a real issue at Rochester General, and they're doing all kinds of things to try to correct this problem, but all kinds of patients were being incorrectly radiographed because, of course, then they have the language barrier. So we're, you know, you say Rosado, Rosario, and they all stand up, and and the students and the per diems, they don't know. So it has been a big issue. So this is here because of that kind of situation. I'm sure we're not the only place. Another thing I'm going to tell you about that work group, we were from all over the country, all over from different geographical parts of the country. We all had exactly the same stories without ever talking to each other, and I'll tell you some of them as we go through, but this was one of them where people were getting wrong information. And now on top of that, just, originally in radiology departments, it was just the work lists, and now it's the whole chart that's electronic. So we have nothing to physically make you feel better when you go out and identify your patients. Just imagine the problems it's causing. When the radiographer has any kind of question, just like always, you should consult with somebody. One of the problems with the electronic charting and the electronic ordering is you're not really sure exactly who to ask, because the doctor's name, nobody's name is right there. They're being entered by, as always, by department secretaries or office secretaries, and they just go into the system. And the other thing that is happening is they go, and there's a list of exams that comes up. So say it's a wrist. It'll come up wrist, 2 views, wrist, 4 views, wrist, APA, lateral, cast wrist or something like that. Most of these people who are doing the ordering, again being secretaries or receptionists or somebody like that, just pick the first one. So what's happening now is something that we used to do a full study on, like a wrist, a 4-view wrist or 3-view wrist, is going in as a PA and lateral. Well, at Rochester General again, and I know this is happening at other hospitals because I have spoken to other people about it, if it's being ordered PA and lateral, that's all the hospital's getting reimbursed for. So they are not allowing full studies. So the only option would be to call every time you get a 2-view study and say, is this really what you want, or do you want the full study? So then you do the 2-view study because that's what they're telling us to do. We used to just go ahead and do the 4-view, whether it was ordered PA and lateral or not. We would do the full study. And then they would just say, go ahead and do the full study. So now it's only the PA and lateral. I hope you're following me on this. And now the radiologists and the ordering physicians are going, well, where are the other views? And so the techs are between a rock and a hard place, because it seems as though we'd have to call on every single case to get the correct order. And really, how practical is that? So that's another little thing with the electronic charting and all these electronic records. And so that's just something that we have to be aware of. It seems as though you shouldn't have to say this, but we should be screening our patients for the potential of pregnancy. For some reason, it seems as though some of our good behaviors have gone out the window, again, because of all this electronic stuff. This is another thing. There's no piece of paper. There's no chart that you can go in and look at, so it's like out of sight, out of mind. People aren't even thinking to ask. It's an amazing thing. So now departments are having to post big signs. I mean, we've always had signs that say, if you're pregnant, inform the technologist. Most of us have something like that. But there used to always be that backup that the tech knew that they were supposed to ask people of a certain age. And I know different hospitals have different age groups, age limits. It's roughly 12 to 55, 10 to 55, something like that. But we're not screening our patients for pregnancy. And it's happening more and more because people aren't getting all the information for them to look at before they go in and do the study. So this one, I think Ann talked to you about this morning. I wish you were in here for this one. The use of the highest KV possible within the optimal range. And what that means is, what would really, if you think about what optimal KV means, it is the minimum amount of KV necessary to correctly penetrate a part. Now, where I trained and how we did it, where I trained and worked for many years in Buffalo, we did the little formula. We took a caliper, we measured the part, we doubled that measurement, and we added 30 or 35 or whatever what we called the room base was to get the proper KV for that part. And that is a tried and true method. Some books say that that's not exactly accurate, but you know what? It's pretty darn good and it's pretty darn close. And I will tell you, when you do that, that assures that you're getting appropriate penetration of the part. And that should mean that the appropriate amount of KV is reaching your image receptor and being read by your, whichever it is, your CR plate or your detector, your direct capture detector. So getting a range of appropriate KVs for a part, Ann gave you a list of suggested KVs, frankly, I think a little high on some of them, but the idea is to have enough KV to penetrate the part because our detectors respond to the amount of remnant radiation that they are getting. And that's what's giving you your index readouts and the appropriate kind of image. We'll talk a little bit more about that kind of stuff a little bit later. When your KV is high, your MAS should be roughly low, you know, the kind of inverse kind of thing. So you want to use the lowest MAS possible to keep the dose as low as possible and still assure that the amount of radiation reaching the image receptor is correct. So many places I know use something at like 2.5 at 50 kV for a hand. Well, you may want to try to consider raising that kV up a little bit, or 50 kV, raising that up a little bit and lowering the MAS. I know this is hard because so much of our new equipment has a limit as to how low your MAS can be. I know when we do experiments at school, you know, sometimes we say, well, half your MAS. They go, well, it's going to be 0.67. Well, I mean, for those of us who are older, 0.67 MAS is like incomprehensible. But it will work with most of the newer equipment and the falling load generators and that kind of thing. But that should be your goal, highest KV within the optimal range. And a good way to do this, and I think I talk about it a little bit later, Ann was talking about technique charts. Developing a technique chart where you're encouraging people, and you know, this is a good thing for students to do, using a caliper to get those measurements and help people kind of get a guideline of what those KVs should be for the different parts. For example, those of us who worked with calipers for years and years know that the cervical spine, a shoulder, and a knee are about the same measurement on a patient, on a single patient. And you can roughly use that technique and be assured that you're going to get pretty good results. The only way you really get to know that is by using some kind of caliper measurement, whether you do the KV formula or you're just, you know, looking at a technique chart. I think I'll talk about those a little bit later. I don't want to forget to say that about the technique charts too. AEC, well, AEC is okay, but one of the problems with AEC always has been if your positioning is off, you're going to get a subpar, suboptimal image. If you're centering, for example, a lateral cervical spine and your AEC center cell is too far posterior and the spine is too far anterior, you're going to get an underexposed film. Well, that's even more important with DR because DR and CR. What happens, and it depends on which system you're using, but if you're off center that way, you might get a very high index number or exposure number, very low depending on what system you're using, but have an underexposed film because the detector is detecting that full amount of radiation even though the part isn't being penetrated. So you have to be very careful with that. The other thing that has happened with the AEC, and this has always been the case as well, is the AEC that you're using has to be calibrated to the type of image that's being obtained. There is a difference in speeds between your CR imaging plates and your direct capture. The CR imaging plates are roughly 150 to 200 speed. That's equivalent to, those of us who are older again, remembering what we used to call the detail screens or the fine speed or the slow speed that we'd use for extremities or small parts, a little higher technique, about 4 times the technique that we'd use for other things. And that is, so the CR cassettes are faster than those 100 speed, but they're much slower than, let's say, the direct capture. And they're much slower than those old, what we used to, most of us used to call the regular speed cassettes, those 400 speed cassettes. Again, not to go too far back, but those of us who are of a certain age, remember there were 3 types of speeds way back when. There was slow, par, and fast. And par was that middle one that we all used for most of our stuff. Slow was for those real detail-y things. Fast we hardly ever used, but if you had a larger patient or for whatever reason, we maybe would use the fast speeds. Those went away when the rare earth screens were introduced, roughly about the late 70s, early 80s. And the industry, being competitive, started coming up with all these different ways to come up with formulas, and they were calling them different things. So Kodak had one system, and DuPont, which existed at the time, had another, and Toshiba had one, and Fuji, and Agfa-Gevert, all had different kinds of ways of coming up with techniques. So the industry got together and came up with the number system that many of us became familiar with, 100, 400, 600, whatever. Those numbers were sort of easy to understand because, well, at least for some of us. I know students always have a problem with it, but you knew the higher the number, the faster it was, and you knew that you could use a lower technique. So most of us, as our middle speed, most departments were using the 400 speed. So when the CR cassettes were introduced and they said, oh, just use the same thing, that's what people were doing, and they were getting all kinds of wacky results, mostly low index numbers if you're in that kind of system, or high index numbers if you're in the Fuji or Philips types of systems. The problem is, as we know, the images were coming out okay, but those numbers mean something, those index numbers that you're getting, or we'll talk about those in a little bit. So people were confused as to exactly what to do, and then the DR came along. And the DR systems are very much like the 400 speed. The direct capture systems are 400, and that most of them act like the 400 speed system. If you use more kV or more technique, it'll come out dark. If you use less, it'll come out underexposed, that kind of thing. The behavior is very similar. At least this has been our experience, and this group sort of agreed with that. So if you're switching back and forth from CR to a DR system, you do need to make those technique adjustments. The problem is a lot of people don't know that, and a lot of departments have AEC calibrated for one system or the other. And when they brought in the CR cassettes, they didn't recalibrate the rooms for a slower speed. So if you're using AEC, chances are good that you're not getting the full amount of radiation that you're supposed to, or the full resulting image is a better way to say it, I guess. So you have to be very careful with that and kind of understand your own system. One way to do that is to use technique charts. And technique charts have gone the way of the Edsel. I don't know why we don't have technique charts that are accurate in our rooms. Technique charts are a valuable tool. Again, for years and years, we always had the technique chart. It had every single possibility listed on it. And then as we moved away and those pre-programmed computerized control panels came out, people started doing away with those. Again and again with the companies that developed this equipment, they didn't take into account things like differences in grid ratio and differences in screen speeds. So a lot of those techniques, you know how you always hear this, people will say, oh, it just doesn't work in there. Or I use my own technique because the one that comes up on the machine doesn't work. I hear that all the time. Probably they do work if you have everything in place that's supposed to be there, the right speed screen, the right size grid, a grid ratio, and all that kind of correct stuff being brought together. That technique probably will work. So technique charts help alleviate some of this situation because you can identify if you're using DR, blah, use this, which would be a much lower technique than if you're using your CR. I mean, there's a 2 times difference between going from CR to DR. So that's one thing that can be on there. You can do your measurements that way. You know, if you do your measurements and a patient measures so many centimeters, you can have a whole technique line set up that a person can look at and say, oh, this is the right thing to do. And you can even have and should have some sort of your index range, your index target, or that's one hard thing to talk about here. All the different systems call it something different. But whatever it is, your index number, your EXI, your S number, whatever that term is that you're using, that's one thing that can be on there. The other thing that can be on there is your grid ratio. And I'm not sure if Ann talked about grid ratio or not, but in a single room, you can have 2 different grid ratios. The upright board in Philips, for example, has a grid ratio of about 12:1, always has, as long as I've used Philips equipment, and that's a very long time. The upright board was always 12:1. The table bucky is either 8:1 or 10.5:1, depending on the year that you bought your equipment. Very important that you know that because that's going to change your outcome image. In fact, the misuse of grids, and I don't think we have it in here, but I think that's one of the biggest problems. I think people are getting grid cutoff all the time on their images, and they're getting funky index numbers or readouts because of it, and they were never good with grids to begin with, and now they're not even realizing that they are having grid problems because sometimes the images come out okay. But I just recently, this has been my new thing, I've been playing around with it in our lab, and in fact, I can create a grid cutoff image using a CR cassette where if you just tilt the grid, it's coming out underexposed or white. It looks just like old-fashioned grid cutoff, and I think people just aren't seeing that for some reason. And that's one thing that can be on the technique chart, your grid ratio. So if you're using the table bucky, it can be this. If you're using the upright bucky, you should do that. These are best practices, don't forget. This is the way it should be done. This is the way we'd like to see it done. Just one more word about technique charts, incidentally. The state has been citing facilities that do not have accurate, up-to-date technique charts. It's happened, I know places personally, not my clinic site, I don't want to badmouth RGH, but there are places that have been cited, and I just spoke to Alex Damiani from the health department this week, and he in fact is confirming that. So kind of it sort of is geographical. You know, the state has different inspectors in different parts of the state, but like in New York City and in Western New York, they're a little bit tougher than maybe they are here. I don't really know. But just know, and they're being cited for not having calipers in the room. Just should know that. So go back to your places of employment, look under the table, in the drawers, on top of shelves, dust them off, and put them in the room. And teach people to use them because they're actually a pretty valuable tool. I always said it's like, do you guesstimate how much Valium to give someone? No, but we guesstimate how much radiation to give someone. I mean, just because our results don't show up for years and years, it can only cause, you know, cancer and cataracts. But at any rate, just know that that is something the state is focusing on, as is collimation. And he also talked about this. We have some issues with the collimation in the electronic imaging world, and they are these. Collimation, by definition, is the reduction of the X-ray beam, the primary beam, hitting an anatomical area of interest and therefore your image receptor, your film, your imaging plate, your DR detector. Doing it afterwards is not collimation. And it's happening all over, everywhere I go. When I did this talk in Buffalo a couple weeks ago, I was told that it's rampant at some of the bigger hospitals. I know it's being done at our hospitals in Rochester, and I'm sure it's being done here. The little group that I worked with in Albuquerque, they all said the same thing. Post-processing masking is not in our scope of practice. Hate to tell you this. I'm going to go over some of the scope of practice stuff a little bit later. Our job as radiologic technologists is to position a part, use the central array appropriately, and collimate down to the area of interest within department protocol. The state law always has been you should see 1/4 inch of collimation all the way around on a film screen image. Well, okay, we don't do that too much anymore unless you're working with film screen. If they came in and randomly went through libraries of films, which they used to do, and they didn't see that, a hospital would get fined. It would be cited. So now what they're doing is they're going into the files randomly, the state inspectors, and they're looking for evidence of collimation on the film. If they see all these squirrely edges, you know, going like this and like this, that means it was done post-processing. If they undo the black mask and there's no evidence of collimation on there, hospitals are being cited. You should know this. And so just because we can make it look like it's collimated after the fact doesn't mean we should be doing it. I just had a radiologist resident come in and talk to my pathology class last week on good chest radiography practices. And we asked the question about the cropping, and he said, well, he says, as a resident, this is out of my, what did he call it, his pay grade to do anything about within the hospital. He said, but I can't tell you how many times they have taken off very important pieces of information that I might have seen. And you say, well, how would they know this? How could they know if somebody did that? Well, let's say you post-process your cervical spine. You take it all the way down, because that's where I see it the most. They love to bring it right in just to the cervical spine part. But maybe there was a displaced trachea, which is often the symptom of swelling in there. A good radiologist will tell you, and that's usually a sign of a trauma of some sort or some sort of condition. But you, as a technologist who wanted to look nice and wanted to make people think you collimated, brought it all the way in and cut that part off. And that's something that could be a problem. So then the patient still is exhibiting problems or issues, and they come in 2 days later or a week later, and the next tech doesn't do that, and they see the swelling there, or vice versa, whatever. That can become an issue. The radiologist is responsible for all the data that a technologist puts on a film, whether it's collimated or not. I mean, if it's collimated, the data's not there, they can't be held responsible. If it's there and you take it off, because you've decided it's not important, they can be held responsible for that. There's no official anything from anyone in writing. I think the ACR might be working on it. The state is aware of it and is going to issue a statement or support a statement that says you should be collimating prior to the exposure. That is our scope of practice. That's our responsibility. So all that pretty post-processing, cropping, masking, whatever you want to call it, should not be done. So you tell this to people, like many of my graduates who are working out in the field, and they get mad at me. And in fact, I was told at the one in Buffalo, that one hospital, the radiologists are telling the techs to do it because then they don't have to note it in their report if they see something. But that's something that's going to come back and bite them. As a technologist, if you don't want that data there, you should be collimating beforehand. I don't understand. We teach you centering points. We teach you how to position. We teach you where to put your markers. And then nobody does it. I don't understand. I really don't. I mean, that's all part of our scope of practice. And I'm scolding a little bit, but it's something that is frustrating as an educator to go out and see. It's like when they're not doing things that we taught them, I always say, we didn't teach you that. And most programs wouldn't teach the bad habits. So masking must not be applied over the anatomy that was contained in the exposure field at the time of image acquisition. Please get that word out, because it's very, very important. It's going to become an issue. My understanding, and ASRT tells us things, that there have been some cases of it already. And just to go back to my little resident from last week, he said there was an issue where they did a portable chest or a chest x-ray on a patient through ER or something. The patient was having chest pain. And the chest was normal, but they just caught on the edge of the image a fractured humerus. Well, how often does that happen? That's happened to me many times in my career where they've seen that. If that had been cropped off, they wouldn't have seen it. So just a little something to keep in mind. I think it's very important. The use of lead shielding for anatomic parts that are adjacent to the X-ray field, again, it doesn't seem even possible that we should have to tell this to people. But students, what's the number one thing you come back to your classrooms to say after your first day in the clinic? Nobody shields. All you do is tell us, shield, 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 and then we go out to the clinic and we don't see anybody shielding. Shielding is important. I always compare shielding to, let's say somebody had a bucket of acid and they were going to throw it at you. But if you just put this cape on, the acid would only hit a very small part of you instead of your entire body. Wouldn't you want that cape? Wouldn't you want that acid to not hit all over? So, okay, it's radiation. We don't see the results for a long time. And maybe there's no effects anyway, because who really knows what goes on at the cellular level? And we collimate after all. But it's really a best practice to use shielding, especially when, in all cases, but especially when the anatomic part is adjacent to the field. Thing about shielding when using electronic imaging, and this is even if you use lead blockers for scatter control or anything like that. If you're using CR, the CR reader reads straight lines and straight edges. So if you're shielding and your shielding appears in the middle of an image and it's crooked, you know, it's angled or it's not, sometimes we use an apron and it's not exactly a straight edge, your reading might not come out correct. So that is one thing you have to be careful with when you're doing, when you are shielding, and hopefully we all are. And this may not be true with every single system. Again, every system is different. But, hello? It's Mars calling. You do want to be careful as to how you place the shield and that you use one to begin with. 8, this is another big one. I just don't understand this one either. The use of lead anatomic side markers placed on the original image, not after the fact. You know, this is another thing that I can't even believe we have to tell people. The electronic marking makes it so easy just to do it that way. But what if you're wrong? What if you are marking the wrong side? What if you're just not judging it properly? What if the patient has situs inversus? We just had one at the clinic last week, another patient with situs inversus. Sometimes it's only in the chest. I forget that's called something else, but. Pardon? Thank you. Sometimes so it is only in the thorax, sometimes it's the full body, but how do you know for sure? The Kodak CR cassettes have the little yellow box in the corner to tell you which corner it is, and that's equivalent to the old flashers. But not every system has that, and heaven forbid you're wrong and you have to go to court and defend those electronic markers, and this has been the number one, just so you know, thing that's happened with electronic imaging for radiologists and technologists is the misuse of electronic markers. The hard marker, your little lead letter, LR, whatever, should go on the image receptor, not on the patient, not on the table, not on the gown, not on the outside of anything. It should be on the image receptor. Oh, but it'll come off if I put it on and put it in the bucky tray. Well, the answer to that is use better tape. Just retape it every time, tape it down. It shouldn't come off. The markers these days are real small. But there should be a nice, clear letter. Now, if you have it on there and you can't see it because there's overexposure in the surrounding field, that's okay, as long as it's there. Then you can go ahead and put your electronic marker on to back that up. And you can always tell if you go to the raw image, like if you're using Carestream. How many in here use the Carestream? I mean, geez, not many. My goodness, nobody's raising their hands here. In our area, our neck of the woods, it's almost all Carestream. And we can go to the raw image and find the marker in the unprocessed image where it's like real gray looking. And if you can see it there, sometimes you can drag it in with your, then it's okay to pull it in, but sometimes you can't. But then you can verify it, because if you can see it, the radiologist can see it when they open it up in packs. If you can't see it anywhere, then you have to do something.
We have a DR machine made by GP, and the space in the bucky is too narrow to get any marker into it. So you can't put it in the bucky.
Do you have just the little flat marker letter type things that we used to put in plaques?
You just can't get anything in there, even though it hooks it and pulls it out.
Well, I mean, I guess in that situation, you're really stuck. But the fact is that if you're going to put it outside, not on the image receptor, you have to make sure that you get it in far enough so that it's going to show up in your image. I mean, that's part of the problem. People lack confidence in your positioning. This is why I say, if you use your centering landmarks, have confidence in your collimation, put that marker in far enough that it'll show up, because they're really, really, really unhappy with the electronically placed markers that don't have any kind of verification, any kind of hard marker. At my clinic site, and it's not happening quite so much as it used to, if you don't see a hard marker on there, we have to repeat it. So there you go, you're doubling the patient's dose just because your marker isn't showing up. So whatever it takes to try to get some kind of confirmable ID on their film, that's what you're supposed to do. You know, this is, yeah?
What is the issue with putting it on the patient's film?
Most of the time it's not showing up, or it just falls off, or it falls off to the side. It's a matter of having proper positioning and collimation. If you put it on the patient, it may not make it onto the image receptor. If you put it too far out to the side, it might be off the image. There's all kinds of things that I've seen. Best practice is to put it onto the image receptor. So where am I here? We talked about this a little bit before, the use of grids, the proper use of grids. All rules and theories and everything about grids still apply with electronic imaging. One thing that is a recommendation of manufacturers is to get grids that are specifically designed for use with, in particular, the imaging plates, because that's really when we would need it with the CR. And they do have grids that have lower grid ratios. So just a little bit of review. I know Ann talked a little bit because I heard somebody out there saying, oh, grid ratio stuff. If we remember, every grid ratio has a certain amount of radiation that it needs. Usually the higher the higher lead content, grid ratio, frequency, whatever, the more radiation is needed. Well, the more radiation that's needed ups the dose. And when we use it with a 400 speed, it's all built into the process, into the formula. When we go to a CR cassette now, which is slower, and we're using that higher grid ratio, we're really increasing the patient dose. So companies have developed grids with lower grid ratios, something like 6:1. Those of you who know mammography know that the mammography grids are like 3:1 grid ratio or 4:1, something like that. So with CR imaging, they do recommend a lower grid ratio of maybe 6:1. They've also developed crosshatch type grids, which give you less flexibility in positioning and a greater chance of grid cutoff. But they find that it reduces the amount of scatter much better, so that you're getting a better image, because scatter and CR cassettes are very incompatible. CR cassettes are very, very sensitive to scattered radiation, very sensitive to. So you want more lead, but you don't want that real high grid ratio so that you don't have to up your technique. So I think this is one of the problems with CR. And in particular, when you go to surgery to do something, if anybody's still doing cross-table lateral lumbars or cervicals or anything like that, where somebody else is holding the grid, or it's put in some sort of a holder, and that grid is angled just a little bit, that's going to give you grid cutoff. And then if it has a high grid ratio on top of that with the CR cassette, you can just imagine some of the issues that are going on. So you have to be really, really careful with your placement, and if at all possible, and I know grids aren't cheap, I know this is not something departments want to run out and buy, but a lot of the portable grids that you have in your department already are probably 8:1, the portable types that you slide into, and if they are, then that's not too bad. You don't have to up your technique too much, but you want to make sure that you use a grid, especially on parts that measure over 10 centimeters. This has always been the rule. But again, with CR in particular and DR as well, it's very, very important because of the effect of scattered radiation on our imaging. It's an additive thing with our DR imaging, and it's sort of like a negative thing with our DR imaging, and sort of a negative thing with our CR imaging, so we have to be careful. I've even started using grids now, well, not that it matters, but like on axillary shoulders. I never used to use grids on that, but they come out much better when you do add a grid. This is another one about the use of immobilization devices, keeping in mind that the purpose of this paper was to address some of the radiation safety concerns that have been out there in our field. You probably have heard the stories of the pediatric exams where the children were really, really overexposed, in particular with CT, but then there was the story of the baby Graham in the New York Times a couple of years ago. I would like to say, in fairness to that hospital, the image that they used was a stock image. It was like not anything from that hospital. They showed the baby completely exposed from head to foot, and it was a chest x-ray, portable chest x-ray. And that's actually not an uncommon thing. And a lot of people will do that because they don't want to have to repeat the film. And they also don't immobilize the patient as much because they don't want to take the time or they don't want the parent to get upset. But the use of proper immobilization devices for all patients, whether they're pediatric or adult patients, really helps reduce your repeat exposure. I always tell my students, if it takes you 5 minutes more to do it and you get the patient nice and immobilized or well positioned, then you don't have to repeat it and you don't have to face issues of motion or anything like that. I know in this day and age to take 5 extra minutes for many of us is probably a problem in our departments because I know we're being monitored, but still that extra few minutes is best for the patient. I would say this, and this is hard. It's hard as a technologist, and certainly when I go to the clinic, I'm company, I'm coming from a college. The people who are administering departments and hospitals don't have the same focus as we do. Ours is supposed to be patient care and patient safety, and they don't get the whole radiation dose thing because it's not obvious. Until somebody gets a big burn, right, and then all of a sudden they're really interested in what happens. But we do if we just take that little extra minute and get used to some of these best practices as we're doing our studies so that they become very second nature for us, and it won't take us that long to do them. But use of immobilization, particularly with pediatrics, is very useful.
Can you address holding patients either by parents or by technology?
Well, it's funny you should ask because at our New York State meeting in October, Alex, who is the the bureau chief or the Department of Health, Bureau of Environmental Radiation Protection. He's a physicist by trade, but he replaced Marianne Harvey and Bob Rivera, Bob Rivera was the only radiologic technologist there. Now there are none, so we're teaching him. He said in October that it is okay for tech to hold. It's not against the law or anything like that, just so long as it's not built into your job description. And where you're forced to do it. But a tech can hold periodically. What we teach and what the world of radiation protection in the United States, NCRP and all those organizations will say, and what the books say is, a parent should be a first choice, or somebody who's not occupational. But I always got the residents to do it, frankly. If they want a good study, let them come and hold. But that was me. But it should be somebody like a parent first, and really we should be measuring the dose when we do ask somebody to hold. So there should be a dosimeter available. I know where I go, they don't do that. There's one available, but somebody really has to ask for it. But theoretically, we should be doing that, letting them see or getting the dose on that exposure, but that it is not against the law for a tech to do it, just not as a regular part of their job. He did say that. Cindy, were you there when he said that? Yeah.
It is against the law.
It isn't. He said it's not. He said it's not in the law that says we can't hold. His specific words were, it's okay so long as it's not part of your regular job. So we can confirm with him next week. We're going to see him. But we all went, when he said that.
There's a published hierarchy where they have, we're at the bottom of the list.
Right.
And the parents are at the top.
Correct.
But it's not illegal. It's just a preferred.
Right. A best practice would be to have the parent hold first. Sometimes you don't want the parent in the room, though, you know. Sometimes you just do it yourself. We just had that issue at my clinic site a couple weeks ago. They did a newborn chest, and the nurse held, and they didn't shield. I mean, it was all one of those things. It was in the NICU, and the parent was outside the room, and I don't know, it was kind of complicated. But it happens. But we should be last. Because of the big focus on pediatric dose, the Image Gently campaign and all that kind of thing, there are some things that need to be reiterated. And one of them is pediatric tissue is different than adult tissue. Even if you have two parts that measure exactly the same, say you do an abdomen on a very thin 25-year-old and you measure, and they measure, I don't know, 15. And then you do an infant who's chubby, or a young child who's chubby, and they measure 15. Or have a little distended belly. Say they measure the same thing. Children's tissue is much less dense. It's much less developed. So even though you might get similar measurements, that doesn't mean you should use similar techniques or the same technique as you would use on an adult. So the best practice is to have a specific technique chart for pediatrics, specific set of workable techniques, and I'll talk a little bit more about that when we get into some of the recommendation parts. But again, using immobilization devices. How many of you use the Pigastat? I've never used one in my life. They use it all the time at RGH. I've never put a baby into one because I just think first of all, I don't know how to use it because we didn't have it where I trained, but I always used like a Taman board or a chair or something, papoosed them. I was big on the papoosing. But whatever you use, as long as it gets you a good exposure the first time, is the best practice and the best thing to do. Making sure that your techniques are appropriate. So wherever you are, if you don't have a set